Good afternoon, everyone, and thank you for joining us. My name is Stacy Varghese, and I'm the Director of Leadership Annual Giving and Engagement at St. John's University. Today, we have Dr. Carol Forster, who will conduct a live CE webinar on epidemics, pandemics, and overdose, managing appropriate controlled substance use in 2021. Some housekeeping rules before we begin. If you have a question, please submit it in the Q&A section on the bottom right to panelists and hosts, and Dr. Forster will answer them at the end of her presentation. To receive CE accreditation for this webinar, you must remain on for the entire hour. Now, I'm excited to introduce Dr. Carol Forster. Dr. Forster is Executive Director at Pharm Consulting, PLLC, and Physician Director Emeritus of Pharmacy and Therapeutics and Medication Safety at Mid-Atlantic Permente Medical Group. As Executive Director of Pharm Consulting, PLLC, Dr. Forster is now a consultant and subject matter expert working with various health and law enforcement agencies and institutions to educate and raise awareness of healthcare professionals and the public on matters of drug safety, the opioid crisis, and appropriate prescribing. As Physician Director of Pharmacy and Therapeutics and Medication Safety at Mid-Atlantic Permente Medical Group for almost 30 years, he successfully managed overall drug utilization while continually educating clinicians regarding appropriate prescribing and dictation of prescription fraud and misuse, always stressing the importance of medication safety. She attended St. John's University College of Pharmacy and then medical school at State University of New York at Buffalo. One of the highlights of her career was being asked to give expert testimony before the Senate hearing on Veterans Affairs in March 2015 concerning opioid prescription policy, practice, and procedures representing health systems. Another highlight in her career was being asked to serve as a speaker and panel member at the Clinton Foundation in Johns Hopkins University Bloomberg School of Public Health Forum on America's opioid epidemic, from evidence to impact in 2017. As a speaker at the 2019 National RX Drug Abuse and Heroin Summit, she presented her work related to reducing opioid utilization by up to 78% since 2012 in the Kaiser Permanente Mid-Atlantic region as leader of the Regional Chronic Pain Board and co-developer of the Comprehensive Chronic Pain Management Program. Welcome, Dr. Forster. I hand the webinar controls over to you now.
Thank you, Stacy. Thank you very much for inviting me here, and hello to everyone, my fellow alumni. I'm going to go ahead and start today by introducing this topic. At first, I want to say that I do have no conflict of interest, and it's not advancing the slide. Hold on one sec. Let's try this again. There we go. I have no conflicts of interest to disclose. The objectives today are, number one, to understand the origins of the opioid crisis, to discuss the CDC guidance for prescribing of opioids, to learn the trends seen in controlled substance prescribing over the last several years, to become more aware of the tools and methods that decrease the incidence of fraud and diversion related to prescribing controlled substances, to learn how the COVID epidemic has influenced opioid overdose mortality in the US, and then finally to discuss recent data regarding illicit synthetic drug use in the US. So let's get back to the origins of this crisis. So most of you know how it began, but physicians were encouraged to treat very aggressively when it came to pain. In fact, JACO at the time said, pain is the fifth vital sign, and you must ask these questions for every patient you're treating. This was eventually dropped in 2016, but from 2001 to 2016, this was one of the biggest drivers probably for physicians. Opioids were promoted as being safe. Pain management options that we use today were not always available in all geographic areas. So it was easier in a way for doctors to use opioids to treat pain. There was a significant lack of knowledge about the complex nature of pain for the general practitioner. They just wasn't taught very well in medical school, and there wasn't a lot of experience and there really wasn't a lot of CMEs being offered for treatment of pain. And of course, we cannot forget that pharma did market very aggressively to prescribers to boost their sales. So as a result of this, the opioids became the leading drug of abuse in 2004. I could do total presentations on just this topic alone. There's a lot of information on this, but I will move on. So looking at this in more detail, especially when it comes to the sales of opioids, the sales grew from $48 million in 1996 to $1.1 billion in 2000. In only 4 short years, the sales of OxyContin specifically skyrocketed. It became the leading drug of abuse by 2004. And Purdue Pharma was very, very smart about this. They used some very interesting, ingenious marketing tactics to get our physicians to prescribe their product. And remember, they were the ones who made MS Contin. So MS Contin was losing its patent at the time that they were introducing OxyContin. So they needed to create this market share, but they also wanted to enhance the market share. They gave out all expenses paid symposia on pain management. There was all kinds of bonuses given to their sales reps for getting their docs to prescribe. There were patient starter coupons given with free 7 to 30 days supply. And again, all throughout this marketing campaign, they minimized any risk of addiction, and they said this treatment was very safe and effective. However, in 2007, Purdue Pharma did plead guilty to criminal charges of misbranding. So again, where did we go with all this marketing and what was the outcome? Well, with only about 5% of the world's population, the US used 99% of the world's hydrocodone, 80% of the world's oxycodone, and 65% of the world's hydromorphone. In 2012, 259 million prescriptions for opioids were dispensed in just that year in the US. So that's about 1 prescription for every single adult in the US. There was a series of articles about this crisis in the Washington Post around July of 2019. It's very interesting, again, delving into the details. And what they published was that America's largest drug companies basically distributed about $76 billion worth of oxycodone and hydrocodone across the country in those 6 years between 2006 and 2012, but only 6 companies distribute about 75% of the volume. And as that volume climbed, the epidemic surged. So it increased 51% from 8.4 billion to 12.6 billion. And the states receiving the highest concentration of doses per year were in West Virginia, Kentucky, and South Carolina. And I know a lot of this information is known by a lot of the folks in the audience now, but you just have to remember that this really translates into lives that were affected, families that were disrupted, children that were left as orphans. And this is significant information. The opioid death rate soared in those communities. Even though the death rate was about 4.6 deaths per 100,000 residents in the country, in the counties that had the most doses distributed per person, they had greater than 3 times that rate on average. Okay, it doesn't want me to. Now it really doesn't want me to do it. Okay, there we go. So if you'd like some light reading, and we all have so much time to read now, the Johns Hopkins University actually was committed to preserving the materials that were used in the active court cases regarding the opioid crisis and pharma. They have an archive that contains about 3,300 documents, more than 131,000 pages, and it's in 6 collections, and you can look those up, and it is very interesting reading, I think. So what we know is the trends in overdose death actually have changed over the years. In the beginning, 1999, basically what we saw again was that rise in prescription opioid overdose deaths, and that's that purple line. These were commonly prescribed opioids. And it just, as you can see, the slope was pretty high, going up more up until 2007, 2008, 2009. It flattened out a little bit. But then the second wave came, and that wave was more about the rise in heroin overdose deaths. And you can see it kind of significantly increased at around the same time that the prescription opioids started to go down. Now we're in the third wave, the rise in the synthetic opioid overdose deaths. And as everyone probably knows in the audience, this is very, very significant. Synthetic fentanyl and its analogs and are illicitly manufactured and distributed. And this has given rise to an amazing death rate. And what we know now is probably most of the heroin on the street is laced with fentanyl, as well as many of the street drugs. And that includes not only just opioids, but even benzos and methamphetamine and cocaine. So the CDC recommendations are showing us that there are basic tenets for prescribing opioids. I'm sure everyone here has seen these. These were published in March of 2016. Opioids are not the first-line therapy. I think that's a big, big piece of the education that was given to all our prescribers and our practitioners. We need to diagnose and appropriately establish goals for pain. We need to discuss the risks and benefits. And then we also need to make sure we pick the right drug, use the right dose for the shortest duration, and have appropriate monitoring and know when to discontinue. Assessing the risk and assessing the harms, addressing the harms are very important as well. We have tools, the PDMP being one, I'll go into that a little further, using urine drug testing, avoiding dangerous combinations such as benzodiazepine and opioid prescribing. And then, of course, not forgetting, make sure we're getting the right patients into treatment. And that's where the general practitioner really can help. And so these guidelines, although most people knew most of these before March of 2016, these kind of leveled the playing field and made sure that all of our physicians had access to the right education. Many of our states incorporated these guidelines into some of their laws regarding prescribing. They also associated them with renewal of medical licenses and initiation of licensure. This box seems to keep popping up, sorry. Sorry. I know you guys are probably seeing this. So the three key assessment conclusions are that basically there's no evidence for long-term benefit of opioids in pain and function for chronic pain, with outcomes that were examined at least 1 year later. Most placebo-controlled randomized trials were less than 6 weeks duration. Evidence was available, though, that there is harm from the long-term use of opioids, including abuse, dependence, overdose, MIs, and motor vehicle crashes, to name some. And there was also evidence that there was definitely benefit from using alternative treatments compared to long-term opioid therapies, and that includes non-pharmacologic therapy as well as non-opioid therapy. So I had the opportunity to participate in the committee that developed the National Quality Partners Playbook for Opioid Stewardship. And if you are interested in this subject, this is a great resource. It's basically a guide to help organizations and outpatient clinics and clinicians do the right thing when it comes to opioid use. It gives concrete examples, how to implement programs, how to teach, and how to encourage others to do the right thing. It's actually a great resource if you want to look it up. And I have no, there's no royalties. This is not a conflict of interest for me. I think it's just a great resource for information. So let's talk about the PDMPs or PMPs. Some states use just PMP, some states say PDMP. So the prescription drug monitoring programs are available now in all states, including DC, military institutions, the VA hospitals, Puerto Rico, and Guam. And they can help us identify the risk of opioid misuse or abuse or overdose. We can see a lot of things on the PMP, and as you all know, physicians are required based on their state laws to use the PMP to access it when they're writing prescriptions, and then periodically thereafter. And the actual requirement is varying a little bit state by state. Where I'm practicing, it's upon initiation, and then every 3 months after if the patient continues on opioids. So what we see on the PDMP, we see overlapping prescriptions. We see drugs that are prescribed together in the same class. We certainly see early refills. We see multiple providers. We can see multiple pharmacies, various geographic areas, patients that are traveling very far to get their prescriptions filled by a certain pharmacy they know won't ask questions. We'll see different mixes of chain pharmacies and private pharmacies, large quantities, combinations, like I mentioned before, which are very dangerous, that can be used together, and that's easily seen on the PDMP. And we also can see the doses and how they're increasing or decreasing or trending for doctors and patients. So has this requirement to use PDMPs been effective? It definitely has been. Doctor shopping rates have definitely declined after the use of PDMPs. That metric of 5 or more prescribers and 5 or more pharmacies in a 3-month period decreased by up to 75% from the fourth quarter of 2012 to the fourth quarter of 2013. Sorry, this is coming up again. Comparison of states with and without PDMPs, you can see a significant increase, or I should say a decrease in the availability of prescription pain relievers and stimulants. There's a lot of articles written on the effectiveness of PDMPs, so I encourage you to look them up if you'd like to see more. Here's an example from New York State, which I think you all are maybe in or maybe not. Doctor shopping went down significantly. Again, this is the 5 pharmacies and 5 prescribers. As you can see in the graph, it really showed a significant decrease once people started using the PDMP. So we started educating our prescribers and our pharmacists early on about the fact that we don't really have evidence of benefit for long-term opioids. We have evidence of harm, and there are alternatives. So several studies were done where we showed that, for example, the combination of acetaminophen and an NSAID actually gave you an opioid pain effect. One of the more common combinations that we recommended for our physicians was the use of about 600 milligrams of ibuprofen plus 1,000 milligrams of acetaminophen, gave you the equivalent pain relief of 5 milligrams of oxycodone. These studies showed that there was really no statistically significant differences in pain reduction at 2 hours between all these groups. So again, what we've learned is that we don't need to use the opioids especially for that acute pain condition, that maybe a fracture or other trauma or even dental work. There's no reason to jump right to using opioids for those, because as we know, a lot of those acute pain conditions morph into a chronic pain condition, and that's how it can start. So again, other studies that showed that the treatment with opioids was not superior to treatment with non-opioid medications for improving pain-related function over 12 months. This is not the only one. This was also mentioned that the results just did not support the initiation of opioid therapy for moderate to severe chronic back pain or hip or knee osteoarthritis pain. Back pain, knee pain, hip pain, these are common symptoms in patients, especially in those over 40, and there's really no evidence that using opioids is going to help these folks initially for their mild to moderate to severe pain. So despite all this evidence that was coming out that opioids were not the best way to treat moderate to severe pain, there were a lot of doctors, a lot of prescribers that were doing it inappropriately. And these are you can read these on the DEA website, but there are a lot of physicians that were being incarcerated after finding that they were guilty of inappropriate prescribing. There's variances in how they were fined or if they were sent to prison, but basically the DEA was doing a good job in trying to find the bad guys. And when I say that, I mean that physicians who are hurting people by using inappropriate doses of controlled substances when there are alternatives that would do just as well, if not much better. Here's an example of I think one of the first times that a physician was convicted of murder for deaths of their patients due to overdose. This was back in 2015. This was in California. This is actually more recent. Just last month, a doctor in Nassau was charged with 5 counts of murder for, quote, depraved prescription abuse. In the documents, you'll see they called his prescription pad a lethal weapon, and the doctor was called a serial killer. If he is convicted of the top charge, it's up to 25 years to life in prison. It's not just physicians. Physician assistants have also been sentenced after inappropriate prescribing. And I don't have a slide for it, but I'm sure that there are pharmacists that have been involved, as well as nurses and other healthcare workers, healthcare professionals. So what happened after the CDC guideline for prescribing? Did that make any difference? Well, it certainly did. Before the guideline was released, there was, you can see the rate per 100,000 patients was about 6250. After the release, 5099. Same thing specifically for high dose or greater than or equal to 90 MMEs or milligram morphine equivalents. We saw a significant decrease in number of prescriptions and the rate per 100,000 patients. So it definitely did make a difference. And again, it's not that we were treating.
My apologies. I'm trying to reach her through her cell phone.
Oh, what happened? Stacy?
You're back.
Oh, okay. Am I there?
Yep, you're here. You're good to go.
Okay. Did we miss this whole slide or what?
Yes, if you don't mind just starting the slide all over again, please.
Okay, sure.
Thank you.
Alrighty, this is just showing us the difference before and after the CDC guidelines were published. A significant decrease in the rate of overall opioid prescribing was seen. In the numbers of prescriptions, especially in the numbers of high-dose prescriptions were seen, as you can see on the slide. A talk about this subject would not be complete unless we talked about naloxone. And naloxone is recommended for all caregivers, family, household members of patients who are at high risk. And as I'm sure most of you know, most states do have standing orders so that a prescription is not actually required. It can be dispensed by the pharmacist to a patient who they feel is of high risk, using the physician as for example, the health commissioner of the state, or sometimes it's different folks, but they do have a name that they can use as far as the physician's name, but it doesn't have to be from the patient's physician. Again, I think one of the most important things is that we're trying to get naloxone available in all areas where there could be overdose death, accidental overdose death. So that means high schools, colleges, YMCAs, emergency responders, even canine units. I think for me, I think naloxone should be as available as a fire extinguisher. If there's a chance of a fire, we can always find an extinguisher. Well, if there's a chance of an overdose death, we should be able to find naloxone. So nasal naloxone, I'm sure the pharmacists know all about this. We want to give this to high-risk patients at discharge if they've received emergency care for intoxication or overdose, if they suspected opioid use disorder or non-medical opioid use, if they're taking more than 50 MMEs a day, and that's actually a law in several states, or if they're returning to use returning to a high-risk setting, such as if they're being incarcerated. And it's also recommended for patients who may have unreliable access to emergency services, or maybe who are just released from prison, or maybe who are resuming opioid use after abstinence. Again, it should be counseled, especially the caregivers and the family members, household members, friends. People should know how to use this. There is actually an app on your phone that you can download that can help you through this. It's very easy. The nasal naloxone is simple to use. You don't have to be a medical person to know how to use it. Again, the standing orders are helpful that it can be given and should be given to anyone who could be possibly at risk for an accidental overdose. Again, also remember it should be given to patients who also have a prescription for methadone or buprenorphine, have a history of any acute or chronic pulmonary disease, history of kidney disease, liver disease, or heart disease, that are also using other controlled substances like opioids, and also with a known or suspected excessive alcohol use or dependency, concurrent use of benzos or other sedatives, or known or suspected poorly controlled depression. Again, if you're having opioid prescription used by any of these patients, it would be a great idea to have nasal naloxone also dispensed. So let's look at New York City's prescription trending since 2013. It's good news. It's showing that the rate of Schedule II opioid analgesic prescriptions is going down over these 6 years on this graph. It is projected to continue to decrease. Here's another graph to show it in a little different way. There was a 19% reduction in annual prescribing rate from 2006 to 2017. And as you can see, all opioids overall significantly decreased. And we do see some decrease in the high dose opioids as well, even though it doesn't seem as dramatic, it is there, and that's important. So the effects of the CDC guidance and the re-education, we definitely did see a decrease. Even though it was already starting to decrease, we saw a significantly increased decline after the CDC guidelines. And again, a number of high-dose opioid prescriptions declined by nearly 50% during this period. So overall, what we know now is that opioid volume is probably going to continue to drop for the 9th consecutive year, a decline of 60% from its peak in 2011. And we're seeing also decreases in those higher dose prescriptions, which is really important, that greater than 90 MMEs per day. We again are seeing greater declines in the use of these prescriptions in those states which previously had the highest per capita use. Here's another way to look at it. As you can see here, it's projected that the rate will actually continue to go down through 2019, 20, and 21. As most of you know, the data for this kind of graph is not always finalized until significant time has passed. So we don't have up to the minute data on this, but it looks like things are still going down. So you might be saying, well, what's the problem then? Why are we still having opioid death? Well, we still are, and we need to continue and not forget about the concern that we still have out there. There are still patients being treated inappropriately. I wanted to show this slide. This is a slide, a poster I presented at the Institute of Healthcare Improvement. And what this shows is how just one particular health plan tried to change the course when it came to opioid prescribing. And it basically showed from 2009 to and again, 2016 to the present day, how the different steps that a national health plan took to try to change and improve the care they were giving for pain management. And using the data they had at their disposal, using electronic medical records with decision support at the point of care, and giving continuous monitoring back to the providers, employing the use of pharmacists, and that was, again, a big piece. What we did was we had clinical pharmacists collaborating with our chronic pain group. We had virtual consults being done by the PharmDs, requested by the physicians. Again, if it was just around the appropriate drug to use for pain or drugs to use for pain, our pharmacists were very helpful when it came to giving some answers to our physicians. It helped to decrease the overall opioid utilization, but at the same time optimizing the regimen and recommending alternative therapies that actually gave better outcomes. So we actually enhanced our pain management by avoiding drugs that would harm the patient and increasing the therapies that would give better benefits. And pharmacists are still very important in this process. So let's change gears a little bit. Let's talk about diversion. So we know what drug diversion is. Basically, there are a couple of different definitions, but basically transferring any legal prescribed controlled substance from the individual for whom it was prescribed to another person for illicit use is, I think, a good example of a definition. So what is the foundation for all of our reviews of appropriate use? We basically use the federal code, Title 21, which is to be valid, a prescription for a controlled substance must be issued for a legitimate medical purpose and by an individual practitioner acting in the usual course of his or her professional practice. And again, breaking that down, the legitimate medical purpose means that the documentation must clearly show that the appropriate diagnosis was reached through all the appropriate means, history, physical exam, and that benefits of treatment were carefully weighed with risks. The usual course means that appropriate standards of care apply to the treatment. So the AMA actually, a long time ago, a few years ago, categorized misprescribers, they call it. So if you have, there are different, they put them in 4 different categories. I thought this was pretty interesting. So there's the deficient or dated practitioner. This is just the doc who just doesn't keep up with education and just isn't aware of what's going on, and they lived in a cave or whatever. But they're unaware of the symptoms of overuse. They seem to be isolated from their peers. Maybe they're practicing far away in a small community and they just don't care about education. And they are getting education from drug reps maybe that are not giving them the right kind of education, or they're just, as I said, just unaware. That's one category. Then there's the duped practitioner. They always seem to think the patient's telling them the truth. They trust everybody. They fall for all those different excuses that patients may use. The dog ate it, I lost it, it was in a suitcase and my suitcase got stolen, and all that kind of stuff. They don't seem to be able to say no when their patient asks for more. Then there's the drug dependent or substance user who might start out taking controlled drugs and then they start asking their staff to get some medications in their own name, and then they use other prescribers' DEA numbers. They can call in scripts in the names of family members or other patients and then pick it up themselves. And this actually does happen, which is a real shame. And then there's the deliberate or the dealer kind of practitioner, and they basically prescribe for patients they know to sell drugs to others. Their office becomes a pill mill. They're selling drugs for money or other things. They become basically a mercenary, and certainly these are the bad guys. So outbreaks of infectious diseases have occurred throughout the years because of significant drug diversion. This is just a graph between 1983, as long ago as that, all the way up to 2013 or 15, whatever, and it shows how many of the different infections have been, outbreaks have occurred because of diversion. And again, an example would be a nurse who's diluting a medication after she's taken some herself, and then use the same needle. There's different ways this can happen, but we've seen everything from bacterial sepsis to viral disease. Significant morbidity and mortality has occurred because of diversion. So let's talk about the pandemic. So what we don't, let me just preface this by saying that we don't have all the data yet. And we have snippets of data and people are collecting it. And I'm sure we're going to have a lot of studies on what happened during the pandemic as we go forward. I tried to give you as much as I know at this point. So we know that fentanyl overdose rates increased in early 2020. There is an overdose detection and mapping application program, ODMAP they call it, which showed a 16% higher overdose rate in February 2020 than February 19, and then up to 42% more in May of 2020 compared to May of 2019. Kentucky also reported a 17% increase in emergency room services given before and after the COVID state of emergency declaration. But what we have also noticed is that ED admissions more than doubled, while other ED admissions dropped. Here's the ODMAP graph for you to see. It's easier to see on this. So 2019 is burgundy and 2020 is gold. And again, this is up to April, but I think what we're going to see is a lot more data coming out of 2020. At this point, we don't have a whole lot, but we're working on it. There's also changes to medication-assisted treatment. Again, outpatient or even MAT clinics saw that there was especially in buprenorphine dispensing, they saw that there was a change. There was actually increases in new patients, more e-prescribing, and more of a day supply per prescription, higher day supply per prescription. That may be due to the fact that the DEA relaxed restrictions on outpatient buprenorphine dispensing. And for example, that included waivered physicians could prescribe to new patients via telephone or telemedicine. They could prescribe to existing patients by any method, and they also encouraged the use of electronic prescriptions. So it actually was a good thing that we had more patients getting more MAT. This may be something that we need to continue. Here it is in a graphical depiction. So basically this is a trends in use of the prescription opioids and MAT. You see the big dips, but then you see it kind of did slowly return back to somewhat normal rates. Again, the new to brand prescriptions are the green lines. And then you can see the dark is the continuing brand prescriptions and the light blue is the total prescriptions. So other effects. So basically we saw 44% fewer patients were started on new prescription therapy, opioid therapy. Total opioid prescribing declined 16% at the peak of the shutdowns in late April. And there were significant variations across different specialties. There were longer opioid prescriptions. The duration was longer to mitigate the COVID disruptions. Basically, things tended to return to normal as time went on. But we did see a significant cluster of states with both opioid and MAT use above the national average. And I can show you that on this slide, where you can see that some states had both lower opioid use and lower MAT use. Some states had higher opioid use and higher MAT use. And then some states, again, had lower opioid use and higher MAT use. So I think the more desirable one would be those light blue ones. And of course, the worst one would be these light green ones, having lower MAT and higher opioid use. Again, prescribing dangerous combinations, I've mentioned this before. We have seen that the opioid and benzo combination treatments have declined, but less in patients over 65 than in the younger patients. That's a little concerning. I have a graph to show you this. About 18 million seniors are using prescription opioids, benzos, or a combination, which represents about 30% of the 59.4 million Americans receiving these medicines. And although prescribing the combination is down by 30% since 2016, the number of seniors that are estimated to be receiving a combination is still substantial at about 1.2 million. Here's a graph that shows that. So basically, the co-prescribing has significantly decreased in those under 65, which is great, but not so much in the over 65. It is decreasing, and that's good, but not as much. So illicit drug use. Are we seeing more illicit drug use due to the pandemic? So right now, I don't think we can say that with a significant evidence behind the statement, but it's interesting. We have some folks noticing difference. This is the PharmD staff of a health department or health plan in San Diego, and this was in April 2020. And this is a direct quote. What they've seen is that the urine drug screening positivity rate for methamphetamine increased significantly. It was an 18.2% increase over the previous 90-day period before the national emergency was declared. And they also saw the fentanyl positivity rate increasing a 35.6% increase over the same period. And they both were statistically significant. And of the urine drug screens that were submitted by doctors treating those with substance use disorders, there were double-digit increases in positivity for cocaine, methamphetamine, heroin, fentanyl, and non-prescribed opioids, which in past had been declining. So even though it's not absolute data, it does seem that relapse risk was significant during the pandemic, and spikes in drug overdoses were significant. So let's talk a little bit about the synthetics. Synthetic opioid-involved death rates increased by 10% from 2017 to 18, and they're continuing to significantly increase. And what they've seen is that they're not increasing with the amount of fentanyl that's prescribing. It's not it's actually it's actually almost contrary to what we're seeing with fentanyl. So the increases in the synthetic opioid-involved deaths are being driven by increases in fentanyl-involved overdose deaths, but the source of fentanyl is not pharmaceutical, it's not prescription, it's more illicit manufacture. So it increased about 55% in New York City alone between 2015 and 17. It's definitely a major contributor to cocaine-related fatal overdoses, and as I said before, it's pretty much seen in almost all heroin at this point. About 36,000 people died from overdoses involving synthetic opioids in 2019. And again, as I mentioned, we are assuming, or we think, that preliminary data is showing that we're going to see an acceleration of that in 2020. So what is this IMF, as they say? Well, it was first seen in 1979. It was called China White. It was a mysterious substance. They actually saw 112 deaths involving fentanyl or fentanyl analogs in California between 79 and 88. And then we come back to where we are today. At this point, we're using urine fentanyl test strips to try to check street drugs for fentanyl and fentanyl analog combination. We're assuming that, as I said, a lot of the street heroin is got fentanyl in it. It's being used to lace these street drugs, and it is a very, very highly dangerous. As you guys know, the carfentanil can be up to 10,000 times more potent. It's very much a big problem. This is a trend in overall overdose death rate from 99 to 2019, all ages by gender. You can see the male versus female differences there, and male being higher than female. And there was a little bit of a plateau seen right before the pandemic. And now this is fentanyl versus other drugs. Fentanyl was involved in 60% of the overdose deaths in 2018. And you can see the data is pretty significant. So what are we going to do? Are there ways to combat this? Well, the DEA is working on trying to get these sources of fentanyl, but at the same time, we have to think about what can we do. And there are folks working on fentanyl vaccines at this time. And the vaccines are very interesting. They're basically coupling the fentanyl and fentanyl derivatives to protein carriers that can then be used to produce antibodies. And they're seeing in in mice and rats right now that they're getting antibodies that can bind fentanyl and prevent it from getting into those receptors. And what we know is that if we can decrease the fentanyl in the receptors down to below 50%, we can probably save lives. And what we've seen with these vaccines, at least in these rodent trials, is that they're reducing brain fentanyl levels by 50 to 80%, depending on the dose of fentanyl that's taken. They're reducing the respiratory depression, and they're reducing the amount of drug that's in the brain. And it's great because it seems to be working with the derivatives as well. And it's also good because it seems like the naloxone is still able to work in these animals even after they've had the vaccine. So it can reduce at least the rest of the effect. So I'm going to end now at this slide. Basically, what we've said is that there's been significant improvements in opioid prescribing of controlled substances, especially in the last decade. We are definitely more aware, everyone, pharmacists, nurses, physicians, anyone in healthcare is more aware of the lack of benefit and the significant risks of long-term opioid treatment for chronic pain conditions. We've also learned about better treatment for pain. We've enhanced our treatments for pain that are non-pharmacologic and non-opioid. We have seen increases in overdose rates, though, and we feel that it probably could be due to some of the effects of the pandemic. We need more data. We're going to continue to see this data come out over the next few months and probably years. We see increases in synthetic opioids and illicit drugs, and they've definitely increased our overdose death rate. And of course, drug diversion, fraud, and misuse continues. So really with vigilance and education, of course, getting folks into recovery, using medication-assisted treatment, more research in the anti-fentanyl vaccines, and treatment programs are some of these important ways that we can manage this epidemic during a pandemic. I'm going to end there.
Thank you, Carol. I do see one question that came in.
Okay.
It is.
Go ahead.
Okay. My question is related to the management of PDMP and its effects, namely heroin pandemic. As a professional in this field, can you give us some insight on the approach that U.S. is taking versus other nations to address use of heroin and opioid abuse?
Yeah, there's you know, I want to recommend a book. There's a book by Johan Hari, and maybe some of you in the audience have read it. He basically was a former person with a cocaine addiction, actually, and also other drugs, and he luckily recovered from his addiction. But in this book, he goes through what other countries have done to try to combat this epidemic, and he talks a lot about injection sites that are run by healthcare providers and the similar programs in various cities and countries, and how that changed their opioid use disorder rates and death rates. And it's a very enlightening book. So yes, we do see different ways of approaching this epidemic in different countries. And I know that some areas of this country are starting to do that. So the theory is that if we have someone with a substance use disorder, if we can manage them medically and allow them to trust their healthcare delivery system to help them with their disorder, just like any other disease process. And if when they need their fix, so to speak, they can get it in a controlled setting and not have fear of fentanyl or other analogs being in their drug. So I honestly think that's a way to go. I think we need to look more into that. And certainly there are more studies coming out from that. And it has been done in different parts of this country, not that many. And it has been done in several other countries, though. I don't know if that answers your question.
Thank you. I don't see any other questions coming in. I think you gave all the information that everyone was looking for. Do you have any final thoughts to share?
I've been trying to give kind of a varied talk, and I know the audience is varied. There's pharmacists, toxicologists, maybe physicians. There's folks from a lot of different backgrounds and a lot of different levels of knowledge about this subject. So if anyone has questions regarding any specific areas and they want to contact me, feel free. I'm available on LinkedIn. If you're on there, you can probably find me and send me a message. Feel free. I think that's the easiest way to go.
Wonderful. Well, thank you everyone for joining us today, and a very special thank you to Dr. Forster for such an informative presentation. Later today, you will receive a form through email to fill out and return to receive your CE credit. To view Dr. Forster's extensive bio, please go to stjohns.edu/APD series. Here you will also find a schedule of upcoming webinars and past recordings. I hope you will join us next week, Thursday, April 29th at 9 a.m., where we will complete our networking series on building a resume and discuss the networking letter, cover letter, and thank you letter. In the meantime, have a great rest of your day. Thank you.